Okay, this section of the lecture will focus on the core assessment. There will be 6 components to this. Principles of core stability, breathing, intra-abdominal pressure, the Sarman abdominal levels, McGill endurance testing, and the functional movement systems. So the unconscious reaction and speed of contraction are most important components of functional stability, not strength. So it's a misnomer and it's a misconception and perception that is put out, I would say, predominantly by the fitness industries and potentially even other medical providers that abdominal strength is what is otherwise necessary. Rather, it's not so much the strength, but the coordination of the muscles that are necessary to be able to provide sufficient stability segmentally and functionally for the lumbar spine. Very small increases in activation of the multifidi and abdominal muscles is required to stiffen the spinal segments while still balancing and mitigating the amount of compression that is going to occur around the spine. And so it's important to consider this, right? So we know that individuals with low back pain and chronicity of symptoms will often overly recruit some of the superficial and the global muscles, as we talked about with Bergmark earlier in today's presentation. And as such, this added compression will create a feed-forward mechanism, as it may cause additional symptoms, additional pain, and additional disability, which will then further the individual to otherwise stiffen their torso artificially, providing them less of a functional stability to the core and segmental reactive forces, but rather more of this compressive and non-therapeutic means. And so it's important when we're considering the principles of spinal stability to understand the balance that exists between the stiffening of the spine and the what you could consider as being protective and functional stability versus over-recruitment. And it's put really nicely in this quote by Vera Garcia in 2007, and this researcher has done a considerable amount of work with Stuart McGill as well, who also discusses this balance between compression yet stiffening of the spine. So trunk muscle coactivation increases stability of the trunk and decreases the movement of the lumbar spine, but at a cost of increased spinal compression. And asymptomatic, this is specific to asymptomatic healthy populations, but it's a principle that I hold dear and at the forefront of my thought and consciousness when I'm prescribing core stability interventions, is that how can we get the greatest training effect for spinal stability and spinal stiffening without having this increased spinal compression, which may otherwise be present secondary to the stabilization strategy that the person is currently using. In the spine, stability is achieved through control of mobility, as described by Page, 2004. It's also common that we hear that rotation or obliquely directed forces demonstrate to be the most potentially hazardous effect in the trunk, i.e. twisting around axially around the spine seems to be the least buttressed with sudden loads. I.e. the prime example of this is the prevalence of low back pain in golf. Okay, so McGill describes a fit motor system versus a less fit motor system when it comes to the spine and particularly the low back, and how we as humans can otherwise have sufficient stabilization and therapeutic stabilization and stiffening without compromise. And so in his fit motor systems model, he talks about how we simultaneously breathe and meet the spinal stability challenges of a particular task with less variance of stability during that task. Whereas the less fit motor system task results in high degrees of variability in the stability and sometimes forcing greater coactivation, and consequently compression is exceedingly elevated as compared to your healthy spine or your healthy fit motor system. So these could be construed as a little bit complicated images here that you see on the right-hand portion of the screen. I want to kind of simplify and make them clear to you as they reinforce the less fit motor system as described by McGill. So in the bottom, or the B image, you can see that you have two lines going in oscillation. On the y-axis, you have spinal stability, Newton meters per radians, etc. The units are less important. Really, it's just an idea or conceptualization that this is the oscillation of spinal stability over time. So one of the lines represents the thicker of the two lines represents the stability of the spine, or the stabilization component, and then you have the ventilation of the flow of ambient air. And you can see how these are directly connected to one another. So as we breathe, inhale and exhale, that the oscillation, the stiffening index of the lumbar spine correspond. However, in the top image, or the one that's labeled A here, we can see that around 25 seconds there's a significant increase in the amount of stability, and that there's also a lot of variability that is lost when the individual is put under demand. This is an example of a less fit motor system in which the individual is getting excessive recruitment and variability of recruitment that can not only lead to temporary losses in stiffness, but they can also add the increased spinal compression that has been described previously in the slides, and then also which is touted by McGill and other researchers as being somewhat detrimental over time as a preferential recruitment pattern and stabilization pattern of the lumbar spine. So at the foundational level of the balance between spinal stability and spinal compression and stiffening of the spine is intra-abdominal pressure. And intra-abdominal pressure regulation is said to be a means by which we can safely and therapeutically stabilize the spine. These images illustrate intra-abdominal pressure and what it means. And perhaps this is a term that you're familiar with. If not, we can discuss it further. So in the first image to the left, you can see how the combined forces of the diaphragm as well as the pelvic floor and the deep core muscles create abdominal stability and spinal stability by providing almost like a convexity, if you will, against the lateral abdominal wall and keeping tone there. So the far right image is the one that illustrates adequate and optimal spinal stability via the intra-abdominal pressure regulation, whereas the central one demonstrates an altered stabilization and inadequate intra-abdominal pressure regulation. In the right image, you can see that there's different postures, not estranged from that of Kendall, which we had looked at previously today, but really what is emphasized here is the loss of intra-abdominal pressure that comes with these altered postures. And specifically, they talk about it as the open scissors concept, where you have a lack of parallel between the crura, or the diaphragm, and the pelvic floor. And so this lack of paralleling prevents the adequate regulation of the lumbar spine via the intra-abdominal pressure. So in the ideal, where the chest and the pelvic axis are horizontal and parallel to one another, you can see that the yellow arrows representing the compression or the stabilization in all directions allows for the sustained pressure, whereas in the other three examples you have abnormal stabilization, and thus the little blue arrows denote the areas that can have additional tension as a result of the abnormal pressures that are otherwise maintained within the abdominal cavity. 2008 out of JOSPT looked at a review of the correlation between intra-abdominal pressure and muscle activation studies. What I would like to highlight is really 4 of their findings rather than going in depth too much within this study. So the first is during expected perturbations, the transverse abdominis is activated to increase dynamics trunk stability by increased intra-abdominal pressure. That means prior to limb movements, for instance, your body's going to naturally increase the intra-abdominal pressure via the transverse abdominis and the other deep core muscles as a means of stiffening and protecting the spine. Then you have the spinal stiffness, which has a positive correlation with intra-abdominal pressure. During spinal extension, the erector spinae activation is associated with intra-abdominal pressure regulation and increase. Increase in rectus abdominis, however, did not attribute to the intra-abdominal pressure development. Thus, it would suggest that the training of the rectus abdominis would not be a sufficient means by which we can teach individuals to regulate and sufficiently stabilize their spine via intra-abdominal pressure regulation. So in short, an increase in IAP leads to an increase in spinal stability. Intra-abdominal pressure regulation leads to spinal stability and good breathing regulation under load. The deep core muscles are most responsible for this. This includes the diaphragm, the pelvic floor, and the transverse abdominis. To operate under automatic and subconscious feed-forward control mechanisms that precede purposeful movement. What this means is that often this is subconscious. This is something that occurs preemptively before an intentional or expected perturbation, and that the regulation of IAP provides anterior lumbopelvic stability, not only statically, posturally, but also dynamically. Great, moving on to the breathing assessment. And along with that, intra-abdominal pressure assessment and regulation. Okay, so this picture here denotes the first form or position in which breathing can be assessed. So it's in sitting with the patient feet hanging off the edge of the table, not on the floor. Abdominal wall expansion, movement of the chest during respiration, scapular position, and spine and head position, as well as symmetry of these body parts and body regions are observed. Gentle palpation of the intercostal spaces of the lower ribs and separation are monitored, and you're gently feeling for tension with an expansion of the posterior lateral wall of the abdominals. And this is also considering the amount of stability in regards to intra-abdominal pressure regulation, in addition to the natural bucket handle motion of the lower rib cage. Normal test. So you can see the different components shown in the left-hand column. Symmetrical posterior lateral expansion, widening of the intercostal spaces, balanced activity of the abdominal muscles, maintaining intra-abdominal pressure when exhaling. That means that there's still some tension left within that posterior lateral wall of the abdominals, and then spine elongation. So they're not collapsing, they're not going into lumbar or spinal extension on the inhalation, nor flexion on the exhalation. Abnormal tests, so things that you may see with this assessment, is absent or weak or asymmetrical expansion of the posterior lateral abdominal wall, insufficient widening of the lower chest and intercostal spaces, cranial movement of the chest and or shoulders and scapula elevation, and spinal flexion or extension with exhalation and inspiration respectively. And Though the criteria is laid out here, I will say that it often takes deliberate practice and consistently looking at this assessment across patients for the practitioner to really glean confidence at discerning between normal and abnormal breathing assessment in sitting. So here's an example of it.
Elevation. The exploration phase of tidal breathing is a passive process where the rib cage would shift caudally to return to its baseline position. My hands are placed on Linda's back. My thumbs are placed lightly on her paraspinals. My second to fourth fingers are placed on the intercostal spaces of her lower ribs, and my little finger is placed on her posterolateral abdominal wall. In this video clip, observe how my fingers move in a posterolateral direction as Linda breathes in and returns to its baseline with minimal to no movement of the trunk, chest, or shoulder girdle.
Okay, and that would be a normal assessment.
Elevation.
Okay, looking at the abnormal pattern, and you can see this one is labeled a chest elevation.
Video clip demonstrates a faulty respiratory movement test with chest and shoulder girdle elevation. Observe my hands on her lower costal ribs moving in an upward direction, indicating the dominance of accessory muscles over the diaphragm during respiration.
Okay, same faulty movement pattern with rib cage elevation.
Close-up shot demonstrates a faulty respiratory movement test with chest and shoulder girdle elevation. Observe my hands on her lower costal ribs moving in an upward direction, indicating dominance of accessory muscles over the diaphragm during respiration.
Okay, next moving to intra-abdominal pressure assessment. Patient position in supine. Hips, knees, and ankles are 90 degrees of flexion. Hips mildly abducted and externally rotated with the limbs supported on the chair, the therapist's legs, or the elevated end of the table. Chest is passively taken into neutral position or expiratory, so you're setting the patient up for success. They also may need or require the head of the table to be elevated so their cervical spine is in a neutral position and that they're not in cervical extension. Given the reflex between the deep neck flexors and the abdominal wall, this will be an essential component in order to get an accurate assessment of the breathing in the supine position, but also the intra-abdominal pressure. Observation, you're looking at the activation of the abdominal muscles, the movement of the chest during the testing performance, and the position of the pelvis essentially you're looking for the formation of a cylinder versus like hollowing or looking for peaks and valleys. Movement of the shoulder girdle would be abnormal, and then position of the cervical spine in the head neck position as previously mentioned. Similar palpation to what you were performing within the sitting breathing assessment, with the exception that you're more on the anterior lateral portion, and you can reach your fingers around for the posterior lateral wall, palpating the similar anatomical locations, again as in the sitting position. Normal test is shown in the left-hand column. Balanced activity of all abdominal muscles. Chest is kept in a neutral or caudal position, so they're not getting any ribcage flaring or elevation. Lower chest widens during the inspiration and is not lost during the expiration. Pelvic floor and diaphragm stay almost parallel to one another, so they're not going into any anterior pelvic tilt and or excessive lower costal margin elevation. Infrasternal angle is close to 90 degrees, and navel observation should stay stationary or move caudally upon giving the patient the weight of their limbs. Where if the weight of the legs are otherwise resting on the therapist's thigh, then there would be a slight reduction in the assistance and or a slight elevation of them if the legs are on a supported surface, such as the elevation of the table and or a chair. Abnormal tests, so there's a number of compensations that you may see here with hyperactivation of the rectus, which would manifest itself with peaks and valleys along the anterior and even the anterior lateral abdominal wall. Insufficient activation of the lower abdominal wall, and so this can be assessed through palpation right above the inguinal ligament. Cranial and cranial lateral migration of the umbilicus. Inspiration position of the chest. The chest isn't maintained in a neutral position. Hyperextension in the thoracic or lumbar junction. Abdominal diastasis. Concavities of the abdominal wall above the level of the groin. Shoulder protraction, cervical spine hyperextension, and overactivity of the superficial hip flexors would all be indications of an abnormal test or assessment here.
In this video, Kelly is placed in a supine position with hips and knees in 90 degrees with her legs supported on my legs. Soon after she breathes out, she is asked to hold the position without support. What I am assessing is her ability to maintain the neutral spine position and cylindrical shape of her abdominal wall. I'm also observing for any excessive activity at her neck, shoulders, protraction or elevation, and if she is able to maintain the hips in slight abduction and lateral rotation. Okay, breathe in, breathe out. Good. Can you bring your legs off my legs? Beautifully done. Good. And you can continue keeping to breathe. Excellent. Excellent. And let it go.
So an abnormal pattern would look like this.
All right, breathe in, breathe out. Good. Can you tighten up your tummy? And let it down. Breathe in, breathe out. Tighten up your tummy. Let it go.
So you can notice the abdominal, the rectus abdominis dominance there, with an additional elevation or prominence of the costal margins upon the cue of abdominal tightening or hollowing. And then from the sagittal view, you can also notice the lumbar extension.
Breathe in, breathe out, tighten up your abs. Okay. One more time. Breathe in, breathe out, tighten up your abs. Okay.
Okay, once again, you see them going, the patient going into lumbar flexion and over recruitment and over dominance of the rectus abdominis again, though the extension moment is not appreciated, and nor is the costal margins. There is additional compression that's going through the lumbar spine with the flexion moment. Okay, so you can assess the breathing in sitting and supine, and then the intra-abdominal pressure also in supine, with the additional demand of holding the weight of the limbs. And so this, as you can probably glean from the assessment in the videos, is a bit more subjective and requires additional clinician practice in order to get comfortable with being able to have good consistency and validity as far as what you're assessing. In order to bring objectivity to it, one tool that can be utilized is the Core 360 belt, which is a belt that goes around the midline of the abdominal wall, very close to the level of the umbilicus, and it uses an accelerometer and pressure gauge to indirectly monitor the performance of the diaphragm and the intra-abdominal pressures, and can help to better assist the clinician in objectively assessing both the breathing regulation and the intra-abdominal pressure during these assessments. We'll move now to the Sarman abdominal levels, with the assumption that the patient has had or has a normal breathing pattern, is able to sustain intra-abdominal pressures. Now it's time to utilize both of those techniques and those skill sets with the Sarman abdominal levels to stratify the patient's performance. And so here's the sequence of core assessment that is endorsed and recommended. So breathing is fundamental. All patients need to be able to do it, and hopefully do it efficiently. Then they need to be able to regulate intra-abdominal pressure while breathing. Intra-abdominal pressure with dynamic limb movements, which will incorporate with the Sarman progression, which really speaks to the coordination here. And then the stabilization endurance, and then segmental stabilization. And for clarity, the stabilization endurance is done through the McGill endurance battery, and the segmental stabilization can be performed in more functional based movements, such as the functional movement screen. Okay, so the Sarman lower abdominal tests. In the left-hand column, you can see the patient position, and then the criteria here in the right-hand column. So patient supine, hips, knees, ankles in accordance with the respective levels. Costal margins parallel to the pelvis and both perpendicular to the table. So same position that you assess the intra-abdominal pressure in. Observation, you're looking for activation of the abdominal muscles, movement of the chest during the test performance, and position of the pelvis, formation of the like the formation of the cylinder there, or more of a barreling or bracing rather than your hollowing strategy. And then you're utilizing the Chattanooga pressure gauge or biofeedback unit, starting at 40 millimeters of mercury, and a normal performance would be less than 10 millimeters of mercury of fluctuation in one direction or the other as the person or the patient goes through their dynamic limb movements in the respective levels. Okay, so Shirley Sarman has described at least 5 levels of the lower abdominal assessment. There are a couple sub-levels that are thrown in that can provide a graded exposure for your patients in getting to the next level as means of practicing. In the first column, you have the numerical level. In the second column, you have the description of each of those respective levels. You can see that level 0 starts with the inability to actually complete any of the levels, and so this may represent a similar position to what you actually did the assessment in, where the patient is actually practicing diaphragmatic breathing in intra-abdominal pressure or lateral abdominal wall expansion and tension regulation while maintaining a normal breathing pattern. Each of these additional levels will be denoted in the following slide. Keeping in mind that the grading system is correlating to increasing EMG activity of the abdominal musculature. Criteria for sufficiently passing a particular level would be less than 10 degrees of millimeters of mercury fluctuation with the Chattanooga biofeedback pressure cuff that is located in the small of the low back, right in the lordosis, just above the PSIS. It's essential with this that you're starting the patient, before you even titrate the pressure up of the pressure gauge to 40 millimeters of mercury, that the patient is starting in an optimal position where they have a parallel positioning of the costal margin and the pelvic floor. Thus, their pelvis is perpendicular to the table, and so is their costal margin. This may require additional manual assistance to get them there, and then it also may require some external support, such as the cervical flexion assistance with the head of the table as previously described. Okay, so we'll go through the levels 1 through 5 of the abdominal test or assessment here. So the first one, so the patient is in the 90-90 position, or the crook lying position, and one foot is slid out while they're maintaining the pressure at the low back. The biofeedback unit is not shown here, and this is level 0.5 with the heel slide. So they are not yet able to sustain that 90-90 position. Okay, so this is level 1. Okay, so notice that the knee remains flexed at 90 degrees throughout. Often people will potentially compensate subconsciously by flexing their knee rather than extending their hip to achieve the motion. Okay, level 2 is one foot's held in the 90-90 position while the other one slides out. Though the video denotes the alternating position with one foot going down and the other one coming up, this is actually described as is both legs are held in the 90-90 position as the foot slides out. Level 3 is predominantly different than level 2 from the standpoint that the heel is no longer sliding, and as the foot fully extends, there's going to be an additional extension moment at the lumbar spine that the patient is going to have to control, and this can be monitored again through the pressure cuff that is positioned at the low back. Level 4, you go back to sliding. However, it's a double leg slide out. Typically, it's stated that once a patient can sufficiently do level 3, that they can get off the table, and you as the clinician can progress them to more weight bearing or different positions that are a bit more demanding. And then level 5 would be the same as level 4, with the exception that the patient would be kicking the legs out and they would not be contacting the floor, and thus there would be further demand and extension torque at the lumbar spine that they would have to control while maintaining a normal breathing pattern. Okay, next in the progression will be the multifidi assessment. So the multifidi muscle fibers are shorter and arranged in tighter packed bundles as compared to the other erector spinae of the lumbar spine. This creates a physiological cross-sectional area that is greater than that of the other paraspinals, and also enables it to produce a large amount of force, but with small excursion. That means minimal movement of the spine, which is consistent with its contribution to stabilization and the segmental stabilization of the spine, particularly with dynamic movements. So the multifidi muscles can be categorized into deep and superficial. The deep have a unique property of being predominantly type 2. They can react very quickly and in response to external stimuli, preemptively activating prior to the onset of a reflexive movement. They cross only two segments. They provide compression with limited extension moment and relevant segmental control of the lumbar spine. Whereas the superficial muscles, in contrast, work similar to the other erector spinae. They cross up to 5 spinal segments, generating spinal extension and a lesser contribution to lateral flexion and rotation, similar to, as I mentioned, the iliocostalis and the other muscle groups that make up the erector spinae of the lumbar spine. To move the spine or increase stiffness, and they also act in co-contraction with antagonistic muscles. And you can see a diagram of both the deep superficial fibers and then finally the superficial fibers shown in the image to the right. Extensive number of studies have been done looking at the neuromuscular control and stabilization of the lumbar spine. In particular, if we're focusing in on the multifidi, there's several different studies that are consolidated here. So let's look at the different tasks. So first, the rapid external triggered arm flexion and standing, the movement shown there. And then the primary muscle role is to an anticipatory activity to counteract the reactive spine flexion moment that would come from the arm acceleration. However, in studies with experimental pain, we see the deep multifidi increased activation, where the superficial multifidi having non-significant changes, same with the erector spinae. However, with the self-paced arm elevation and lowering and standing, again, the primary role of the muscles are to elevate, with elevation and lowering, is to counteract the spinal flexion from the arm's mass. And then when we see this in the presence of at least acute pain, there's an elevation to 90 degrees where the deep multifidi and don't have any real significant changes, but with the lowering, there is an increase in the deep multifidi, adding to potentially more compression. When we look at additional tasks that are not as simple as simply just raising the arm, at least in standing, so we have the forward and backwards weight shift. The predominant role here is as the spine moves forward, the spinal extension is activated to maintain the upright trunk, and backwards we get a co-contraction with the flexors, again stiffening the spine to maintain balance. In the presence of experimental pain with the forward lean, there's a decrease and a delay in the deep multifidi. And then with the backwards sway, there's less of a significant change. They still act in a co-contractive fashion with the flexors. The prone elevation of the arm is related predominantly to the clinical test that we'll go over. And when we look at this, we see that in a healthy individual, the activation to extend the spine to aid in the arm elevation. And this is, again, in a preemptive fashion, in an anticipatory means of timing. It should lift prior to the onset of the arm actually lifting off the table, and then also with active spine extension. However, in the presence of pain, the deep multifidi are decreased, at least with the arm elevation, and then with the back extension, in the presence of pain or nociception in the lumbar spine, then there's a decrease in both the superficial and deep portions of the multifidi. What about with trunk flexion? So typically there's a lowering, there's a relaxation at the end range of flexion. One of the reasons why we are critical in coaching our patients not to flex or deadlift below the parallel. The multifidi will lose their length tension relationship as well as their line of pull to resist the segmental shear. With elevation, that is upon return, there is activation to assist with the reverse of the action and pulling the spine up to an erect position. What happens in the presence of pain, with the lowering, there's no erector spinae relaxation, and they actually increase in their activation, adding additional compression in an awkward position. And then with elevation, the erector spinae are decreased and inhibited during that elevation compared to the control. Significantly, also in walking, with stance, there should be an activation during the stance limb, and then a relaxation during swing. However, this is altered, again, in the presence of pain or nociception, where the erector spinae on the stance limb are decreased, and then with swing, there's an increase. So there's an altered coordination around the multifidi and the erector spinae that are stabilizing the spine during your gait, particularly in the presence of pain or those with chronic low back pain. A classic study that was done by Hodges where we had the slow trunk flexion and extension around neutral, where they look at the healthy individual that has a co-contraction of the flexors and extensor muscles to stabilize the trunk around neutral. However, there's a variable increase in unpredictability with the presence of pain. Thus, the anticipatory and the reflexive stabilization of the lumbopelvic complex is otherwise compromised. Needless to say, the multifidi are drastically affected not only in the acute, subacute, and the chronic low back pain patient. If we look at this across time, we can see in the first week that there's a significant increase in the muscle inhibition. Acute size reduction and vascular and other mechanisms are at play that causes this size reduction. There can be some adipose activation, acutely at least, and then the regenerative pathway is activated as a means of trying to heal the process. And then around the 3-month mark, if this was otherwise to persist, there's maximal intervertebral disc degeneration that can otherwise occur due to the lack of stability segmentally. When we draw that out to the subacute and early chronic phases of low back pain, there's a pro-inflammatory cytokine phase that leads to slow and fast muscle transformation. That means that those type 2 start to transition more to a type 1. They are less responsive and less reactive to perturbations and anticipatory quick movements. There's a fibrosis of the muscle, and then there's also a fatty infiltration that sets in. The onset of fibrosis and fatty infiltration, slow to fast, happens around that 6-month mark. And then if there is not resolution, not only in the pain response and the nociception around the lumbar spine, or if fear avoidant behaviors otherwise set in and inadequate activation via rehab and targeted exercises are not implemented, then you can fall into more of the disuse and the deconditioning phases. The muscle and the muscle fiber type continue to atrophy, and the fibrosis becomes more progressive. And this is where you get into the stage 1 and or stage 2 of the fatty infiltration, which we'll discuss. And this leads to a late development of muscle fiber atrophy and further cascade, perpetuating a cycle of disability around the lumbar spine. So though there are tests that have looked at the erector spinae, particularly like with your planking, one specifically for the multifidi would be the multifidi lift test, which looks at the spontaneity and the reactivity of the multifidi as the individual lifts their arm. Now, traditionally, this is going to be described with anywhere between 1.5 to 3 pounds held in the hand. And I'll play the video here with. So in this video, Kyle Kiesel will describe the multifidi lift test. Due to the constraints of the recording, you won't be able to view it by hitting play here. You'll have to scan the QR code and watch it on your mobile device. I'll also provide the hyperlink at the bottom should you want to also click on it and see it on the actual PC or Mac. In addition to just the activation and the functional assessment, I would also encourage you to look at the imaging, if available, for your multifidi assessment. Specifically, fatty infiltration of multifidus muscle is strongly associated with low back pain. Here are a couple of key points. The correlation with low back pain. So increased fat infiltration in the multifidus muscle is often observed in individuals with low back pain. This infiltration is linked to decreased muscle function, decreased stability, and contributes to the persistent pain and the severity of the disability that the individual experiences with low back pain. The impact that it has on muscle function, this fatty infiltration can lead to atrophy and reduced muscle strength of the multifidi, as well as the reactivity as you saw in the previous video. They're impairing their ability to properly stabilize the spine preemptively in a anticipatory fashion, and this also leads to further dysfunction in, at times, if persisted, that degenerative disc disease, as well as additional osteophytes and further facet arthropathy. And then as this will then lead to exacerbated pain and limited mobility, further declining the disability of the individual. Then mechanisms, the infiltration is thought to result from disuse, injury, or chronic pain. The previous cited article from Hodges in 2019 does a fantastic job at laying out the sequential fashion and the mechanisms at play that lead from initial injury to acute, subacute, and then eventually chronic, and how that affects the multifidi, not only their function, but the fatty infiltration, the atrophy that persists. In this, the multifidi can be inhibited from normal muscle activity and leading to the degenerative changes, as I mentioned. And then neuropathic and metabolic factors may also play a role in the multifidi changes. What does that mean for us as rehabilitation specialists? It means that we need to have targeted exercise and physical therapy to help reduce this fatty infiltration and improve muscle function and potentially alleviate the low back pain. Understanding the implications that low back pain has on this multifidi muscle, its function, its atrophy, as well as the fatty infiltration and the structural changes is crucial for developing effective treatment strategies for your low back pain patient. As such, as I alluded to historically in our live lecture, as well as earlier in this lecture, is that though treatment can have an individuality about it and we can respect the gray, the assessment really should be black and white. And so if you intend to change the fatty infiltration, the muscle atrophy, and potentially the muscle function, then getting baseline assessment, I think, is critical to demonstrate actual efficacy of the interventions that you employ. So how do you go about assessing the quality and the fatty infiltration of the multifidi of your patient? So the gold standard right now is going to be a cross-sectional T2 and an MRI machine. However, as Kyle Kiesel had mentioned in the previous video, that you can certainly do it via diagnostic ultrasound, and that's an up and coming and further expanding diagnostic modality that we have within our clinical practice. Yet still today at date, the cross-sectional MRI is going to be the mainstay. So it's important first to be able to orient yourself to the MRI. So you're looking at a cross-section of the lumbar spine. You can see the IVD as indicating the intervertebral disc. The PM on either side is the psoas major. Lateral to that is the QL, and then the erector spinae. And then in either gutter of the spinous process, you can see that you have the multifidi on either side. So this can be this can help you determine the current state of the multifidi. And again, you're looking for two things. You're looking for the amount of bulk, that is the amount of muscle atrophy or lack thereof, as well as the amount of fatty infiltration. So what does that look like? It's helpful to identify exemplars of what is healthy and unhealthy. So here you have normal, mild, moderate, and severe atrophy, as shown by each of the four figures to right. So the normal is comparable to what you saw in the first diagram or image. And you can see the amount of red and the high percentage that makes up of the multifidi. And then the mild atrophy shown in the image in the top right, which shows slightly smaller than the first, and then the moderate and the severe below that, where the majority of the gutter along the spinous process is more white than it is red, or in this case, black. And so you're looking first for the muscle bulk, and then secondarily to that, you're trying to stratify the amount of fatty infiltration. Now, when we look at the fatty infiltration grading, it's kind of nice because there's really only 3 grades or levels. So you have fat grade 0, which is 0 to 10%, fat grade 1, which is 10 to 50%, and then fat grade 2, which is greater than 50%. And simply you're trying to draw a circle. You can do so on your markup of your MRI and look at what percentage of that circle is made up of white tissue versus dark gray or muscle tissue. Though there are more quantitative means and protocols that can be used by your radiologist in order to quantify this, for our intents and purposes, though, the nice thing about working in a multidisciplinary healthcare setting is that you can reach out to the radiologist who signs the note of the MRI to ask them for further follow-up. In all practicality, to get a gross sense as to whether there's minimal, moderate, or severe amount of fatty infiltration would be an important prognosis and maybe, yes, an educational point for your patient, but it would certainly guide what additional interventions or an emphasis that you need to put on your erector spinae and specifically the multifidi activation interventions. So the qualitative evaluation of lumbar erector spinae muscle, specifically the multifidi, assessed by fatty infiltration rate, has a potential to reflect dynamic spinal lumbopelvic balance, not only during gait, as demonstrated by this article, but across multiple of the different tasks and the anticipatory tasks that we had previously described in the experimental studies. Okay, moving on to McGill's testing battery. So Stuart McGill at the University of Waterloo, and really internationally renowned biomechanist when it comes to lumbar spine, has a couple of statements here and has come up with the endurance test battery that I'll present next. Given the growing support of quantification of endurance, the data of endurance times and the ratios between extensors, flexors, and lateral flexor groups of the lumbar spine in healthy normal controls are useful for patients evaluated for providing clinical training targets. So that came out in 1999, and there's been a further elaboration and normalization of data since that time frame. Evans in 2007, isometric tests of trunk muscle endurance requires minimal, inexpensive equipment and are safe and simple to employ in clinical settings. Trunk muscle endurance should be tested and trained for in order to get multi-directional competency irrespective of one's gender. And so it consists of the trunk flexor endurance, the lateral endurance, that's the lateral side plank, and then the extensor endurance, which is also known as the Sorenson test. So trunk flexor endurance, the incline is 60 degrees. The patient is in the position shown with the knees flexed and feet flat on the floor. Notice that as the patient begins to fatigue, not only will they potentially drift back towards the surface, but they also may flex further, reducing the amount of force that is going through the low back, as this becomes easier given the lessened vector of gravity working on the spine. They're held 4 inches away, and they should be maintaining that 4 inches or that 10 centimeters. And you can see the normative times shown there with an average of 147 seconds, just shy of 3 minutes, about 2.5 minutes for both genders. Lateral flexion tests, i.e. the lateral side plank, is shown here. You denote that the bottom leg is posterior to the superior one. Looking for an average of 83 seconds, irrespective of gender, and then the respective gender norms are shown there at 95 and 73 seconds, respectively. Okay, then the Sorenson test, looking for the extensors, this extensor endurance. This is a quite demanding test and often necessitates the assistance of the clinician to be able to hold the weight of the limbs and or using 2 mulligan belts to strap the patient to the table. They can usually use their arms initially if the table is lowered sufficiently to the floor. before the test begins. The outcome is seconds, and then you can see the denoted times shown there with an average of 171 seconds when you pool the males and females. So the ideal scoring of the test battery is not only hitting the normative data, but also having sufficient ratios between the flexors and the extensors, the lateral stabilizers and the extensors, the right and left lateral bridge ratios or lateral plank should be to 1-to-1 ratio. You'll notice that the extensor ratio should consistently be the longest of all the tests, with the highest ratio relative to the lateral bridge endurance. Okay, once the patient has been able to demonstrate sufficient endurance with the test battery, then you can look at segmental dynamics stability with the functional movement systems. So the functional movement screen is a pre-participation screening tool that utilizes 7 tests that can be scored from 0 to 3, where 0 being painful movements, whereas 1 through 3 showing sufficient competency of movement, with 3 being the highest score. The goal is 2 or above. It's not to max out the each assessment. So it's shown to be a reliable tool when used in untrained practitioners. Less than 14 of a total FMS score is 11 times more likely to become injured throughout a particular sports season. Military recruits with less than 14 FMS score are 2 times more likely to become injured and not graduate from training camp. And asymmetries in the FMS scores are 3 times more likely to be injured over the course of a season. So when you look at a systematic review of the psychometric properties and the reliability of the FMS, that you can see that consistently that there's good to excellent inter-rater reliability, and intra-rater reliability has also shown to be good to moderate. There are a couple studies there, as you can see, that have shown lower scores, but the predominance of the evidence suggests good reliability. It should be noted that it is recommended that you do several screens and get familiarize yourself, where reliability of the practitioner really is established after 100 repetitions. All right, so the ability of the tool to predict injury. So you can see the cutoff scores are consistently around 14. There are a couple that have looked at higher scores, and the overall odds ratio of subsequent injury anywhere between 1.5 to 11 times more likely. This is dependent on not only the demographic, but then also of the researcher involved here. You can see the sensitivity and specificity values also shown. The purpose of this talk is not so much on the full FMS, but rather focusing on the dynamic trunk stability and using the trunk stability push-up or rotary stability components. So the criteria for the 3, 2, and 1 are shown here. So for males, they perform the push-up lying flat on the ground with the thumbs aligned at the top of the forehead, whereas the females, the thumbs are aligned at the chin. They're instructed to maintain a rigid torso as they push themselves up as a single unit from the floor, with their toes tucked under them and their knees locked out. There's specific verbal instructions that are given by the practitioner, which is quite similar to the ones I just verbalized, and will improve the reliability of the practitioner when they use the formal script. A 2 is that they're unable to perform level 3, and for the males, they move their thumbs down from the top of the forehead to the bottom of the chin. For the females, the thumbs are aligned with the clavicles, and they're able to push up as a single unit without any lag in the hips or the shoulders. Same instructions, the patient is asked to push up as a single unit with the preliminary instructions of tucking the toes under them, locking out their knees, stiffening their core, and pushing up as a single unit. A 1 is that they're unable to do it at that new position for females at the clavicle, males at the chin height, and a 0 would be that they perform the action, however it's painful. Rotary stability, performed correctly where they are straddling the board. They maintain contact with their foot, their knee, and their opposite thumb. They fully extend, come back together, tap their elbow to their knee, re-extend, and come back to the starting position without a loss of balance and without a excessive asymmetry or weight shift. If they are unable to do that, then you do the contralateral limbs, which is more traditional and consistent with your bird dog. Same thing, they start in the starting position, extend one arm, the opposite leg, come together, touch elbow to knee, re-extend, and come back to the starting position without a loss of balance, and while maintaining contact with the hand, the knee, and the foot. 1, they're unable to perform the task, and 0 is they have pain while doing so. And here are the references.